everyone. We will be live in 1 minute.
Oh, okay.
Dr. Awad, I will tell you when to start. Once we cross 100%, I'll let you know.
We have our.
When do I have to share my screen? Only to know that.
Once Dr. Awad will start, will complete his speech, he will hand over the mic to you. Then you can share.
Okay. And only after that you start then.
Yes, after Dr. Awad start, once he will complete his speech, he will introduce Saudi German Hospital Group. He will introduce speaker and panelist. Then he will hand over the mic to you. Then you can share your screen.
How many participants do we have in total?
Let's see. Let's see. Smart Podium, can you put us on live now? We are live.
Well, the number is.
Dr. Awad, you can start now. We have crossed 200.
Okay. Good evening, everybody. Again, with one of our regular scientific webinars for the neurosurgery department in Saudi German Hospital Group-wise. As you know, Saudi German Hospital Group is a well-established group in Saudi Arabia, and it's expanding across the Middle East, going to Dubai, to Cairo, North Africa, and some areas in the region. And for the last decades, the hospital is providing both the medical service and academic service as well. And one of the academic services presented by the group is hosting an international visitor professor program that help exchange information and provide better service for the patient, and making sure to keep updated all the time, and giving the latest state-of-art practice to the patients, which improves the quality of the service given to the patient, and also promote the scientific and academic progress of the physicians. And especially for the neurosurgery department, it's a rapidly expanding department. In all the branches, the departments and most of the branches is equipped by state-of-art equipments, and ensuring the up-to-date service in all directions. And today's webinar is really interesting because it gives an idea about one of the not recent service. It's an old service in the neurosurgery field, but it's rapidly and widely expanding this era, which is functional neurosurgery, and basically the effort done by the scientists to modulate the human behaviors and the human functions. And this is one of the dreams, that one day you may be remotely controlling other people. So for the time being, the functional neurosurgery is working on neuromodulation, or modulating the function of the brain, for the time being trying to control abnormal functions of the brain. And maybe in the future it will promote adding more functions to the brain. And of course, most of us heard the breakthrough event of Elon Musk about the brain chip he is thinking to put, and how he will control people, trying again to alleviate some of the human suffering, but at the same time there is maybe potentiality for control of human behaviors. And today we are lucky, we have a top-ranking panelist in Saudi German Hospital, Professor Mahmoud Sabri, the head of the chief neurologist in the group from Riyadh. He is the man who his work resulted in keeping the hospital one of the stroke units in many of the branches. And also we have from Dubai, Professor Mohammed Fouad. He is my friend. He is a top-class neurosurgeon. And on top of this, we have our eminent speaker, Professor Alish. He's an old friend and is regularly in touch with the Saudi German Hospital Group, all branches. And we have the honor to work with him in different time era in the past and in many branches, and hope we'll see him soon in one of our activities. I'll give you a short introduction about Professor Alish. Professor Alish is the, I can say, one of the gods of functional neurosurgery. Professor Alish was born in Luxembourg. He is a professor of stereotactic and functional neurosurgery. He has medical studies in University University of Vienna. He also has neurosurgical training in Germany with a special focus on neuro-oncological and functional stereotaxy. And when it comes to stereotaxy, Professor Alish is one of the people who knows the know-how of these techniques. He was graduated at 1989 at the Medical University in Vienna, Austria. He is one pioneer. He is one of the pioneers in deep brain stimulation for movement disorders, mainly Parkinson's disease and essential tremors. He started as early as in the 90s. Today, he is the main clinical interest in focus on surgical therapies for neurodegenerative disorders like pain and brain tumors. Professor Alish, he has now the position as a head of the Neuromodulation department at the Paracelsus Clinic in Zwickau, Germany. I hope I spoke the name properly. Besides that, Professor Alish is one of my mentors, and we consider him as a close friend. We have the opportunity to meet him many times during my work in Saudi Arabia. We have a lot of cases done together and a lot of development he has been sharing for the last decade. And I'm sure he will be one of our constant international visiting professor and the level of the medical service and the academic activity as well. I don't want to speak or waste your time. I know you are waiting to hear the coming lecture from our Professor Alish, so I will let him give him the talk now and see you after his meeting for discussion with the panelists, and we can receive your question as well. Professor Alish, please introduce yourself if you would like. I have a good introduction, I think, and you can start share screen. Thank you.
Okay, let me say some words before I share the screen so you can see me. It's late here. It's late for you. It's late here too. So we go to bed early. Typically, we go to bed at 10 o'clock at the latest. My family is sleeping. I know that in the Arab countries it's different, so you stay up longer. It's Ramadan. It's another reason to stay up, to be awake longer. But it's a pleasure, like always, to be there. I prefer being there physically, definitely. It's more than a year that I have not been there. I was last in the Jeddah, so in Saudi Arabia, I think it was in February 2020. And I expect to go there back soon. So they are working on my papers. But I must say that I'm in close contact with my friends there because we have this wonderful institution of webinars and Zoom and conference calling and all these things that we didn't have before the pandemic. We must say that this is something very, very positive that the pandemic brought to us, that we are able to do such things that we are doing tonight. And I'm extremely jealous, I must say, that we have an audience with 720 people now. It's so marvelous. It's so amazing. And I hope that I will not disappoint you because I will tell you something. I will talk about something that I talked already about 1 year ago. And I hope that I will not be too boring repeating it. But I tried to rearrange my lecture in a way that it fulfills, hopefully, your interests. So now I will, so I also thank you for the panelists to be there. I'm so happy to see you. Dr. Sabri, I'm so happy to don't see you, Dr. Fuad. He's camera muted. And also, of course, Mohamed Awad, I'm very happy to have you as a moderator here. and I will start sharing my screen. So I share. You see it? I will talk about neuromodulation, a game changer in functional neurosurgery, with a question mark. Please look at the question mark, because I will try to let you know if there should be a question mark or an exclamation sign. My disclosures: I've been working with many of neuromodulation companies. I've been working with Medtronic a long time ago. I've been working with Boston Scientific. I was the one who introduced the DBS material in a study in Europe for Boston Scientific, and I'm often proctoring for Abbott, and I have scientific support for Boston Scientific. I forgot to mention, because I think so important as well, I am in the advisory medical board of the MIACO, so of the German hospital group. And it's really amazing being there, because it gives me the possibility to work with them to construct a future for functional neurosurgery. And I think there is a big future for it. And Mohamed Awad said it already. I think this is where neurosurgery is going. Unfortunately, no, not unfortunately. And this webinar, you will learn the principle of functional neurosurgery, the principles of neuromodulation, the indications for functional neurosurgery and neuromodulation, and the future of functional and neuromodulation. If there's some time left, I will also give some outview about that. Now comes the unfortunately, I do not know what is the audience tonight. There are 700 people, and there might be neurosurgeons, there might be experienced neurosurgeons, but there might also be students or people who are not familiar with it. So please, I apologize, forgive me if I'm saying something that you might already know, but it's very important to understand what is functional neurosurgery. Functional neurosurgery is a neurosurgical procedure done for alleviating symptoms of various central nervous system disorders that do not have any gross anatomical abnormality. It's very important, because when you are dealing with tumors, you have a gross anatomical abnormality. If you are dealing, as a neurosurgeon, with bleeding, you do have an anatomical abnormality. If you deal with aneurysms, it's also abnormal. What we are doing is we treat a brain that is anatomically intact, but that is only functionally not intact. So we have an intact brain, and we have to try with our technique to restore the functionality. So this is why we call it functional neurosurgery. And when it goes to the brain, when it goes to the functional neurosurgery of the brain, I think our forefather, our grandfather was Ernst Spiegel. He was a neurologist from Vienna. He emigrated to the United States in the 40s, last century. And he brought it to the point that he said that you can do selective lesions in the thalamus and the basal ganglia to enhance physiological and reduce pathological functions. So this is the starting point of modern stereotaxy, functional stereotaxy. And this is what they did. So they did very small lesions in the brain, cutting pathways in the brain, and in order to restore normal functions. So tonight I will have only 30 to 40 minutes to talk, so I cannot dive too much in all these things. So I will simply go by and mention it. But this is what Spiegel said. This is what he did on the brain. But you can do these things all the way down in the central and the peripheral nervous system, coming from the hemisphere, going to the thalamus, to the midbrain, to the tractus, to the root, the ganglion, and even the nerve. And this is where we, as functional neurosurgeons, we can work on all these levels. And so we can treat epilepsy, pain, movement disorders on two levels, so thalamus and midbrain. The tractus, we can treat pain. The root, we treat pain and spasticity, and then later more peripheral. Typically, we treat pain again in the nerve. So these are the levels where we can act as a neurosurgeon. Classical features of functional neurosurgical procedures, they are typically irreversible. So you cut the nerve, you cut the cord, you cut the brain, or you make a lesion in the brain. It's not adaptable. It's often limited to one side. You can only do it on one side. For example, a thalamotomy, you can only do it on one side. If you do it on both sides, thalamotomy, you are doing it for Parkinson's disease, for tremor, for instance. When you're doing it on both sides, it's very risky. The patient risks to have a speech disorder after. So you are limited to one side. And you do not have any possibility to follow up these patients because it's done. You do it during the surgery, in the OR. When it's done, it's done. It's not necessary, but it's also not possible. But it's affordable. There are not additional costs. I think this is very important. I do not know from where in the world you are attending to have a social base for these systems, but there are other regions that don't have the money to afford for that. So I think my message now should be that the two possibilities on the neuromodulation side and the other on the functional neurosurgical side should be similar. But let's go on. What is neuromodulation? Again, you might know it, but there are persons in the audience that don't know, so I will explain. Neuromodulation is defined by the International Neuromodulation Society. Yes, we have a big society, as an alteration of nerve activity through the delivery of electrical stimulation or chemical agents to targeted sites of the body. It's carried out to normalize or modulate nerve function. This is what neuromodulation is. So we call it technical neuromodulation. We call it technical neuromodulation because it's so important to say that this is something that is based on technology, because there's also a pharmacological neuromodulation, and this could be confusing. There is the pharmacological neuromodulation, the physiological process. Given neuron use one or more neurons to regulate diverse populations of neurons. This is the pharmacologic. Don't talk about that tonight. Only technical ways needs always a device. So you always have to implant a device to do technical neuromodulation. So you are highly depending from technology, from expensive technology, and maybe also complex technology. But we have been able, not we, but the industry, and to optimize it. And when you have a look on neuromodulation on Pubmed, not have a look, but had a look. This is what I did in May 2016. I went to Pubmed for another lecture, and I had a look what happened with neuromodulation over time. And you see that neuromodulation, as we know it today, started somewhere around the 80s. And there were at that time already more than 6,000 publications out. I tried to update this slide for today. I wasn't able. Why? The reason is that neuromodulation is such a nice word, and it has been so often used by everything. It's no longer possible when you go to Pubmed and you ask for neuromodulation, you get more than 100,000 publications. What does not mean that they are all related to technical neuromodulation, what I'm talking about, but simply everybody is using that word. And so if I would have known that, I would have changed the title of my talk tonight. But let's go back to the history. Interestingly, when you go to the literature, you see that the very first publication where electrical modulation was mentioned was by the way, a friend of mine from Austria, Schröttner Otto, who published in '78 about electrical neuromodulation. This is the very first electrical modulation in Pubmed. Does not mean that this was the first paper about that, but that was the first time that this name was mentioned. Let's go back in history. Where's neuromodulation coming from? The forefather of neuromodulation are the cardiac pacemakers. You see a picture from Buchan in 1960, one of the pioneers for pacemaking. This was an external pacemaker. This one, you see another one external, and this one is an implantable. It's made of Balakos, I think it's by polyacryl. And it was possible at that time with electronics, with biocompatibility, and with battery technology, they finally managed to make an implantable system. And we, as neurosurgeons, we are always very eager to grab new technology. And so this is the reason why we were able to adapt the pacemakers to our purposes. Initially, it was for pacing the heart, but we use it for pacing the spine, for pacing the brain, for pacing the nerves. And so you see the family tree of the neuromodulation for neurological disorders. You see dorsal column stimulation, deep brain stimulation, peripheral nerve stimulation, motor cortex stimulation, and so on. So today, for every level, starting from motor cortex stimulation to deep brain stimulation, up to or down to peripheral nerve stimulation, for every level in the brain, we can offer a neuromodulation option. Not an ablative one, but a neuromodulation option. So we have two things, ablative and neuromodulation. And I will give you some example for that. One example, and Mohammed mentioned it already because I think it's my hobby. It's deep brain stimulation, DBS. This started in '87 from a French group, Benabit and Polak, who did deep brain stimulation in patients with Parkinson's disease, with tremor. They implanted electrodes there where the forefathers lesions. And so this was a reversible, adaptable, and non-lesional therapy. You know that. I will not go back to that. And the classical indication for deep brain stimulation today are movement disorders. Works very fine. It's a good indication for doing deep brain stimulation. Dystonia, the same. Dystonia works fine also with deep brain stimulation. There are other indications, psychiatric indications, to, for instance, obsessive compulsive disorders, Gilles-Tourette syndrome. Gilles-Tourette syndrome works perfectly with deep brain stimulation. It's reversible, you can adapt it. It's relatively risk-free. And pain, unfortunately, pain was in fact the very first deep brain stimulation that was performed. So already in the 70s by Hosobuchi, and so they did it already in the 70s of last century, but it was forgotten after. Nobody is doing it anymore. And it's really a fantastic indication for neuromodulation of the brain. So deep brain stimulation for pain. What are the alternatives that we have today? I think we have alternatives. And this is something I want to discuss with you because I said it already. I think neuromodulation is nice, but we should keep in mind that this is very expensive, that it needs a lot of follow-up, and it's lifelong therapy. And there are simpler procedures, the classical one, that are not bad. We have the classical ablation, we have the radiosurgical ablation, and we have the focused ultrasound. Let me explain you that. The classical ablation, this is a picture from the 60s, by the way. I took it because I like it. And this is the classical one. This is making a borehole, entering an electrode, and then on an awake patient, make a very tiny lesion in the thalamus and abolish the tremor. Or in the subthalamus, not in the nucleus subthalamus, but in the subthalamus, so the part under the thalamus, and you can influence also rigidity in Parkinson's disease. This is something I'm still doing today. This is something I would really like to do within the German hospital group, because it's relatively easy, it's fast, it's forever, it works. You have an alternative to this. This is not opening the cranium and doing it with radiosurgery, in this case with gamma knife. I did a lot of cases also with gamma knife. I typically do that in patients that are elderly, where we don't like to open the cranium, and with the gamma knife you can use focused X-ray in order to make the same lesion that in fact you are doing with the thalamotomy, with the classical ablation. And then of course there's new kids in the block, something very exciting that started only 10 years ago. 10 years is a short time in medicine, and this is focused ultrasound. They are popping up now around the world. We have some in Europe. I know that you have one in Saudi Arabia and the Gulf region, probably yes also. And so I think this is another option that will still have to show us that these results are stable, but also you are not using, like in the gamma knife, radiation, but you're using ultrasound. Same idea, you make a lesion in the brain and the patient should be tremor free after that. So we have a lot of options. We have a lot of alternatives to deep brain stimulation. I said it, thalamotomy, classical radiosurgery, and focused ultrasound. Pallidotomy, the same, classical radiosurgery and focused ultrasound. Although pallidotomy, I was told, I do not have this experience, but pallidotomy might be a bit more tricky with focused ultrasound. This has technical reasons. So the question is DBS a game changer? I think yes. DBS is a game changer because it opened us the doors to the neurologists again. Before the advent of modern neurological therapies for Parkinson's disease, it was easy to have patients for tremor or also for rigidity to treat them. But with the advent of medical therapies, or very good medical therapies for Parkinson's disease, so the neurologist stepped back and said, no, don't like that, because it was an irreversible therapy. It was not adaptable. And I think the reason why it was so good accepted deep brain stimulation was because it was reversible. It was adaptable. You could switch it up and on. And so I think this is the reason why deep brain stimulation is a game changer. Although I think that the other therapies like the thalamotomy, pallidotomy, and all these things should still be available. They should not be a noble art, because there have been some tendencies to say, okay, this is a noble art, nobody is doing it anymore. No. I think this should be done again. It's very important, because with a very well-fitting thalamotomy, you can abolish the tremor and don't worry about the future. Patient doesn't need any support in the future. So I think it's very important that we keep this therapy on board, and then we decide what is best for the patient. Because when the patient has bilateral symptoms, we can't do a thalamotomy. Thalamotomy in a bilateral condition is relatively risky. We have to decide patient by patient. But it should be available, and for me, it's very important that we do it. So let's go down now to the next step and come to spinal cord stimulation. Spinal cord stimulation has been introduced in 1967 by Sheely and Mortimer. They put an electrode on the spinal cord by puncture, first open, then later by puncture, and they put the electrode on it and they stimulate. Here you see some pictures showing what's happening. You put an electrode on the dural sac here, and you can stimulate the posterior horns. And this is where pain is going. And with stimulation, you can create paresthesias, and with these paresthesias, you can influence the pain. And spinal cord stimulation has a lot of indications. I think this is the neuromodulation that is mostly done in the world. So I think the numbers are amazing for spinal cord stimulation. And you have a lot of indications for spinal cord stimulation. You have neuropathic pain, you have deafferentiation pain, radiculopathy, complex region pain syndrome as well, failed back surgery. you have peripheral nerve injury, stump pain, and you have ischemic pain. I think the ischemic pain is very important as well, because with the spinal cord stimulation, you increase the blood flow in the vessels. And I think this is an underestimated indication for spinal cord stimulation is the periphery, the ischemic pain. I think it's so important. And unfortunately, it's not so well known, but it works. So we have a lot of reasons to do the spinal cord stimulation. And typically this is not done by neurosurgeons, by functional neurosurgeons. This had been spread around. This is done by anesthetists. Anesthetists know well to puncture. They puncture better than we do often. And so this is something that is in the hands of the anesthesiologists, is in the hands of the pain people, of the pain specialists. And that is good, because you have always to have all in your portfolio. You can offer not only device-aided therapies to your patients, but you should also offer other things. And so I think this is a good development. Are there alternatives? Not that many. There are, in certain conditions, you have dresotomy, you can have a rhizotomy, you have neurotomy. Is it a game changer? Yes, definitely. I think without spinal cord stimulation, functional neurosurgery would be poorer, a lot of poorer. So I think this is really a game changer. And this brought the patients to us, of course, also to the anesthetists. But I think this is really a game changer, spinal cord stimulation. And the industry knows it. I will come back to that later. The industry knows it, and there are popping up a lot of companies bringing new and interesting products. One of these new and interesting products is another kind of spinal neuromodulation. This is dorsal root ganglion stimulation, DRG. Here you do not stimulate the posterior column, but here you stimulate the ganglion. The ganglion is well hidden inside the bone, and nobody was thinking about that. And for me, it's really astonishing to see how long it took until the idea came, why don't we stimulate the ganglion? This was only, I think this publication is from 2013. So this started around 2008, 2009. But this is a nice therapy as well. They're very much the same that you do for spinal cord stimulation, but you have special electrodes. So you can really enter the foramen. You see it on the video here. You can really enter the foramen and you put the electrode very close to the ganglion. The stimulation voltage or the current must be very low because this is a very sensitive region. But this works well, and it works especially well with this indication. So complex regional pain syndrome. This is the best indication for dorsal root ganglion. This is complex CRPS, complex regional pain syndrome, sensory autonomic. So, but this is in fact more or less that what you are also treating with sympathetic blocks. There are alternatives to dorsal root ganglion stimulation. You can have sympathetic blocks when it goes to plexus avulsion or root erosion, avulsion, dresotomy, rhizotomy, medication. I wrote it italic here because it's not fitting. It's not a surgical therapy. But I think sympathetic blocks is something that is complementary or even, competing with dorsal root ganglion stimulation. Because you use also the sympathetic blocks in order to define the potential effect of CRPS. Is it a game changer? We're thinking about that. I don't know. It's too early. I think it's too early to tell it because it's relatively complicated to implant the electrode. It's relatively complex. It works fine. So patients who have it are really happy, but it's expensive. And so I'm not so sure if we will see it. Give us some time and we will see it. The same as for this indication, occipital nerve stimulation. We don't have a counterpart, a lesional one. There's no lesional counterpart for occipital nerve stimulation. You're doing it in severe migraine, you're doing it in cluster headache. So you can't ask, is the game changer, because there was no game. You can infiltrate, you can go on medical therapies for migraine, but of course also medical therapies for cluster. But there's no counterpart in functional neurosurgery. The reverse is this: rhizotomy for trigeminal neuropathy, neuralgia. So rhizotomy of the trigeminal nerve. This is the opposite. There's no neuromodulation available for that. There were some attempts to stimulate the nerve. Forget it, doesn't work. Broke, the electrode broke. No, it was never released as a commercially available therapy. It was only, yes, some nice papers came out. Though I think this is definitely a lesional therapy that works fine. But if you think there's no competition, of course there's a competition. There's a big competition. Now, Dr. Watt, he will smile because he's a microsurgeon and he likes doing the Janetta. No, he switches off his camera. He's back. Now he's back at the sea. So he will later, he will say that. Because there is a competition also for rhizotomy of the trigeminal nerve, but this is not a neuromodulative. So this is a microsurgical one. And there are other kinds of neurothermia. I will not talk about that. I think I do not have so much time. So I will step over to the next kind of neuromodulation, because that is neuromodulation too. This is also technology-based neurosurgical therapy, medical therapy. Intrathecal baclofen for spasticity, of course, also intrathecal opiates for pain. But I will pick out the intrathecal baclofen. This works with a pump. This is also a device for aiding the therapy. It's implanted, completely implanted, and you have a knob here in the middle that helps you refilling the pump. And these pumps are very complex, so they have a motor. They are motor driven and they can make complex application of their drug. There are other gas-driven pumps. I will not go too much in detail of that, but I think this is another kind of neuromodulation. And this is treated used mainly for treating spasticity, all kinds of spasticity, peripheral spasticity, but also supraspinal spasticity. Doesn't work so much and so good in supraspinal spasticity, but it works also. Then, of course, but this is redundant. In fact, this is cerebral palsy and trauma. Trauma is very important as well for that. What are the alternatives to intrathecal drugs? Rhizotomy, dresotomy, and neurotomy. So this is a picture that I have from Marc Sanu. This is his dresotomy. This is from Marc as well. This shows you where we are going. We are dreasing here. We are destroying the dorsal root entry zone. And this is the place where pain is generated. In fact, this is the synapse where the pain is generated, and when you destroy that, you have a good effect on this neuropathic pain coming from nerve avulsions, for instance. And you have, I think this is very important as well. This is a typical functional neurosurgical procedure. I have from Dr. Mahboub from Algiers, and this is what is also now part of the plan in us here. Dr. Ayman is ramping up with the treatment of spasticity, cerebral palsy with peripheral selective neurotomy. I think this is also part of our plan that we are doing without the Saudi German hospital group, the MIACO group. So I think I'm close to the end now. Neuromodulation is effective, it's adaptable, it's reversible, and has a lot of innovative power. I do not know how many students are here in the audience, but this is something that I say to my students when you have to choose about your field, when you want to go with a neurological field, when you want to operate, when you're handy, So neurosurgery is nice. And if you come to functional neurosurgery, there's a lot of innovative power, because you mentioned Elon Musk. You know his innovative power. I don't believe that. I don't believe in this interface. Anyway, but I think we will see a lot of new things in the future. The only thing, it's relatively expensive. Neuromodulation is expensive, needs follow-up, can fail, material can fail, and needs lifelong support or replacements. Bing, this is expensive. This is also good for money. This is why industry is highly interested in that. And I think this is what is driving also this. This might be good, this might be less good, but I think this is, we can't change it. I think we will see a lot of innovations, and I think this is good. And if these innovations are less invasive, if they are reversible, if they can be adapted, it's better than the classical one. And there's a lot of movements there at the time. There are a lot of mergers, companies eating the others. And so it will really, it's a very interesting field in the future. We will see smaller systems. We will see systems that are with closed loop, systems that are registering brain activity, and then they react to this brain activity, like here with the neuropace in epilepsy. So I did not talk about epilepsy today. I hope that someday Ashraf Gobashi, he will do that for me, and he will go on this, because this is also functional neurosurgery. I think epilepsy is also an interesting topic, but I will not be able to cover that tonight. Only to show you some interesting pictures to show that these devices will become smaller and smaller, and they will become smarter. So we will have the possibility to remotely program the patients. We'll have the possibility to remotely check them. I think this is very important. And now with the pandemic, it was very problematic for our patients, because typically patients come in and we see them. And with the pandemic, everything was closed, and this was a disaster. And we did it on telemedicine. We could talk to the patient. Our telemedical activity ramped up extremely, but we weren't able to change the parameters in these patients. And the industry listened to this and reacted already. And so in 1 year from now, or 2 years, every manufacturer in that field will have remote systems. So you can check the parameters, you can change them, you can interact with the patient. The system will become much more smart. So I come to my conclusion. I said it, neurosurgery offers a large armamentarium of effective pain procedures, not only pain, but of functional neurosurgery procedures. The choices of the procedures depending from the patient's general condition, the origin, the nature. Sorry, I have only the pain here in it. Augmentative procedures are safer and adaptable, but also more expensive. Ablational procedures in the hands of an experienced physician offer affordable and stable alternative. So this, I want to see this, what I said tonight, as a plaidoyer for the classical therapies as well. And so I think I come to my end. And if you have more questions, feel free to contact me over email or simply at WhatsApp at the number you see. Okay, that was it. Did not be too long. Stop sharing.
Thank you, Professor Alish. Really, it was very interesting highlight about the how we can wire the brain and the spinal cord, and how we can use the artificial intelligence and the high tech the engineers or the medical engineers provide to us, trying to alleviate pain. As I can understand from your presentation, that we are working hardly to suppress abnormal movements or remove abnormal pains. This is the main interest for the neuromodulation for the time being. And I think in the future, there will be restoration of function as well. So I take one of your last slides about the neuromodulation, and I like this description in one of the advantage. It's reversible. In surgery, we cannot reverse what we do. If we do discectomy, we can't get things back. If we remove the brain tumor, we can't get things back. So in surgery, usually there is permanent damage. So the beauty of neuromodulation that you can reverse everything, and the surgical component is considered minor, and the risks are controlled. And again, the lifelong support that is needed for people who underwent neuromodulation or implanted with a device, as a neurosurgeon, we are used for lifelong relation with our patient. So I'd like to hear another perspective from our chief neurologist, Dr. Mahmoud Sabri. He is the pool for the cases, and he is the one who starts the interface with patients, so he can stratify patients, their needs, their troubles, and at what time they can offer them the neuromodulation as an option for their suffering. So I like to give a chance for our professor, Dr. Mahmoud Sabri, to hear his input or his perspective about the topic we have discussed today. Dr. Mahmoud, please.
Thank you very much. Thanks, Dr. Alish. It's a wonderful lecture, actually, very comprehensive. We wish to have more time, actually, to gain more and more. For the short time, I just wish to say, like you said in the conclusion, this area, there is real need in the medical field for this. That's why even if it is expensive, but it's expanding. It's need many utilities, many activities, more experience. Prices are high, but it's expanding, and the current future is in need because the medical field in need it. Many cases we need. Actually, I just for the augmentative, Dr. Alish with us.
Yes, I'm here.
I need if you have just a brief elaboration about augmentative procedures.
Yes. Didn't understand the question. Is this a question?
Brief definition or about augmentative procedures that you mentioned in the last slide.
Yeah, the augmentative procedure is typically in pain when you do spinal cord stimulation. This is augmentative. When you do deep brain stimulation, this is not augmentative. This is finally some kind of blocking what you're doing there. Typically, you say for augmentative, it's lower than 50 hertz. When you go up to more than 100, it's no longer augmentative.
Right. Okay. Thanks very much. Dr. Muhammad Fouad.
We have also the pleasure to have Dr. Muhammad Fouad, the neurosurgery professor. He is based in Dubai, Saudi German Hospital, Dubai. As a surgeon, you see a lot of patients who are suffering from pains. And most of the time, the pain, we try many tools to define how the level of the patient pains. For the spinal cord stimulation as a sort of neuromodulation for pain ablation, when you decide as a surgeon, now we take the role of the neurologist. We are the surgeon and we should offer something to the patient to relieve his pain. When you decide to give the patient the options of use of neuromodulation techniques to promote or to alleviate his pain condition. So can you elaborate on this issue, please?
Yes, first of all, I would like to thank Professor Alish for his concise and thorough presentation, which covered many aspects of neuromodulation.
تقريبا لو عاوزة تسألي حاجة تحب تيجي أوديلك.
So I would like to talk about this fine cases of neuromodulation, spinal cord stimulation.
Comprehensive.
first of all, we need to be very focused about the treatment of cases and to try to identify what is the pain, where does the pain come from.
Dr. Sabri, you must mute your microphone.
Yes. So the most important to know where is the pain generator. This is the first thing. This is a new thing that has been talking about recently, to know where is the pain generator and to try to address this point so that we can do the good surgery first for the patient so that we don't have a lot of cases of failed back syndrome. And with the introduction of new techniques like endoscope and laser and these kind of pain management techniques, and that we are already doing now, this is getting us to do less invasive surgeries with better outcomes. But for the patients that had major surgeries like fusions and like extensive surgeries in their back once, twice, thrice, and then they still have back pain, and after taking a lot of medications, which are a lot of controlled medicines, which have a lot of bad effects on the body and on the concentration of the patient, I think that at least a trial of 3 to 6 months after these constant pain medicines, after 6 months, if still the patient is in severe pain, then I think that spinal cord stimulation, but I want also to hear the input from Dr. Alish. What is the time limit after a patient that we diagnose by failed back syndrome who already taking like Tramal, Lyrica, or gabapentin, or any other medicines like codeine, anything like that, is taking it regularly and not improving or still have pain? I think it's 6 months, or do we need to wait more?
No, I don't see this this time. I think that the best patient is the one that doesn't need it. Because if you're doing a good job in spinal surgery, so you won't need this. But I would say I don't see any time there. I think this is something that the neurosurgeon who did the spine surgery should decide. In fact, if because he knows the anatomical situation, he knows the history, he knows what he has done, and I think the clinical signs are so obvious, and it's so easy to test simply. Because normally when you're doing spinal cord stimulation, it's very easy. You make a lumbar puncture, you put the electrode and you externalize it, and then you do it for a couple of days or even longer. And then the patient will tell you if this is helpful. And if this is helpful and you see as a spine surgeon, I don't see another alternative because I know the situs, I know what I've done. Why don't you go ahead and do it? Because you want to bring the patient back to his normal life, maybe to his profession, work again.
Yes, it's just like we always look for a time frame. Maybe after the surgery, it's like sometimes there is like the post-operative time, and to give some medicine some time, and the physiotherapy to give it some time after the surgery, so that we can see maybe he will get better. But if he would be dependent on medications, and these medications will have a lot of adverse effects on him or her, then I think spinal cord stimulation, the issue is sometimes that we think of is the cost of this procedure. As you know, the implantation, the test is simple, that we do the test to see if it's working or not. But to implant the device is quite expensive. Even with medical insurance, it's not like easy to have the coverage of medical insurance, because this is a very expensive device that it's implanted in the patient.
Yeah, exactly. Yeah, I think so. This is the reason why it's not that easy to do it, but it works. And if the indication is good, and the trial is okay, then the patients are happy.
Yes, of course.
Dr. Awad?
As I can see from our fruitful discussion, that we are talking about the finance of the services we are providing to the patients. I think the insurance company, by time, they get convinced this is no longer research tool or a trial or experimental therapies we provide to the patient. Once they are established through our guidelines and the protocols, and they are considered as the standard lines of management, I think at that time the insurance company will be obliged to cover this, and they are already covering more expensive issues in other specialties. For this reason, I would like Dr. Mahmoud Sabri, if he's still with us, to comment about, do you think, Dr. Mahmoud Sabri, that for controlled patients with movement disorders, and they are already controlled on the medicine, and they have no complication, adverse effect of medicine, do you think in the future we will provide neuromodulation for this kind of patients, or still we use it for medically refractory cases?
Surprising for you, my answer may be yes. I think in the future, you know, when the medicine, whatever, if it has effect, it has many also side effects. Okay, but with this technological aspects, there is much neuromodulation getting, in a sense, like Dr. Alish mentioned, you normalize the issue a little bit. You use some technical and technology, and at the end you normalize by a very perfect thing. Let me, Dr. Muhammad, I'll take the chance. I have my colleague and one of the eminent doctor in movement disorder, Dr. Heba Shinawi, and she is known to Dr. Alish, and she has a comment to Dr. Alish. I'll introduce, and she will come to join us.
Okay.
Thank you, Dr. Alish.
Hello. What a surprise. What a surprise.
I'm here. Great talk. Thank you so much.
Hello. Hello.
I have a comment for this question. I think the younger is the patient, is the better to use the neuromodulation and surgical treatment. And yes, of course, in the future, I think even if the patient is controlling medicine, and if the patient has no side effects, he will end. We know as Parkinson's disease is a progressive disease, and the patient will end up need surgery. And when he is above 60, we will have a lot of contraindications or a lot of difficulties doing the advanced management. So especially for the patient who has an early Parkinson's disease, I think early neuromodulation is a must, and something need to be considered and addressed to the patient from early beginning of the disease. Don't wait the patient to reach for a very bad side effects from medication or a very bad progression of the disease, because at that time the patient will have a lot of dementia and a lot of side effects that will prevent us from doing the advanced management.
Absolutely, yes, I'm with you. So I was at your meeting, at the movement disorders meeting from Saudi Arabia. I was so excited about that. Yes, it was remote. I was not physically present, but I was there on the screen all the time. I was very impressed, and I completely agree with you that you have to do this surgery not too early, but not too late as well, because it's very important that these patients keep their professional competence, that they stay in their job, that they stay in your family, that they are the father of the family, that they keep their role that they have had all the time. And I think you as a neurologist, you are best placed to know when these patients deviate, last exits before whatever, where you can say, now is the moment the patient should go to surgery. And it's relatively easy. So I didn't want to talk especially now on deep brain stimulation, but as you are asking me, it's so easy because we're doing it in general anesthesia. It's so easy for the patient. The patient gets he sleeps, and when he wakes up, the system is implanted. So it's no longer this terrible awake surgery that we have had for many years. Today, we are able, with the help of imaging and with the help of good technology, with segmented leads, with directional leads, we are able to let the patient sleep, because this is very relaxing, not only for the patient, but also for the surgeon. So I think this is something you can really offer. Of course, I'm a neurosurgeon. I see it very relaxed, because I say making 2 boreholes putting a wire in is not a big thing. So Dr. Awad will agree that he does much more complex things than putting two wires in the brain, but it must be very precisely put. Yesterday, I got a patient who had his electrodes probably placed into the cerebellum. I do not know what happened there, but this should not be the case. So it must be really in place, but then it works.
Yeah, sure, agree.
Welcome, Dr. Eva, for this meeting, and I hope we can see you in more and more future meetings. It's really to meet you.
Definitely.
We got one question from the attendees. We have almost now reaching 1,000 attendee.
Yeah, I'm so jealous.
I think they enjoy the pitch.
It's late now, huh?
So one of the question is, what kind of anesthesia using these kind of techniques? We spoke a lot about a lot of techniques for the brain and for the spine. And so they are asking about the anesthesia. I think you answered in your last statement, but you can elaborate about kind of anesthesia used during the different procedures.
I have a protocol from that. I do not know it by heart, but we elaborated this many years ago when we started to go for deep brain stimulation in general anesthesia. So my anesthesiologist, he made a protocol for it. But at that time, still we kept in mind that the anesthesiology should be in that way that we do also microelectrode recording. We stopped doing microelectrode recording. We are ramping up now a project with macroelectrode, but not with microelectrodes. So I don't think that the anesthesia, the general anesthesia, is really a problem for that. So if there's a question, simply give me an email and I will answer that. I will send it.
So we got another question. I think Dr. Zainab Al-Hassan, the one who asked about the kind of anesthesia. I hope this answers your question. For Dr. Ghulam, he is asking about neuromodulation for vegetative patients.
Yeah.
One sort of neuromodulation for the quadriplegic patient is a phrenic nerve stimulator. We didn't get a chance to hear about it today. This is one of the functional restoration devices that I regain the function, not alter or normalize the function. But I think for vegetative patients, is any role for neuromodulation?
There have been publications out there on this topic. Coadon in France, he did it, and there's another Japanese group who did it also. We were thinking on that. I have really ethical problems with this because I think that patients cannot give consent, and I do not see, if there were dramatic improvements, yes, it would be different, but nobody has ever published a dramatic improvement in this. And so if this is not the case, I would be very, very conservative in this way and say no.
Okay.
I discussed the issue with Niels Bierbaum, who is doing that with patients who are locked in. Not deep brain stimulation in locked in patients, but he was very engaged in that way. And we were discussing it. So, but not really, no. I would not do it.
I have one question myself to your good self. Do you think there is role for neuromodulation in sympathetically mediated or sympathetically involved diseases like hyperhidrosis and complex regional brain syndrome in the form of stimulation of the sympathetic chain?
I don't know. I don't know. There are many publications out there. I don't have any experience with this. But when you go to Pubmed, we would see a lot of publications about even tinnitus and so. I think we should really stick on that, what is proven, where we know that we have a long experience with it and long-term results. This does not mean that there should not be investigations about that. I think making science on this and research on this is good. but I would not say that this is a therapy that we can give any hope to one of our audience or of one of our patients with that. I don't see you anymore. Your camera is muted. Yeah.
So, Dr. Mohammed Fouad, do you need to elaborate before concluding this session?
No, thank you. It's been a very fruitful talk, and I enjoyed the talk very much.
Me too. It was a pleasure being there. And I'm so happy that I don't have to travel home, because I go one step down and I'm in my bed. But it doesn't replace the physical contact that I enjoy very much with you all.
Dr. Mahmoud Sabri, we enjoyed your presence with us today. If you need to elaborate before conclusion.
Thanks very much, and appreciate this effort, and wishing for a near future other talk about epilepsy and other neuromodulation tasks in a separate or more details for each one of this comprehensive.
Yes.
What we know. Thank you very much. Thank you very much.
Okay. Thank you. Bye-bye.
Thank you all for joining us in Saudi German Hospital Neurosurgery Department regular webinars. Really, we enjoyed your company today, and great thanks to our distinguished speaker, Professor Alish from Austria. I would like also to thank our panelists, Professor Mahmoud Sabri, Chief Neurologist of the group, and Professor Mohammed Fouad, our neurosurgery consultant from Dubai, and we also welcome Dr. Heba, our neurology from Riyadh. Thank you all, and hope to see you soon in one of our neurosurgery webinars, and have a nice day. Thank you.